Welcome to This Explainer. Today, we're going to bridge a really crucial gap. We're connecting the incredibly sensitive world of clinical childhood psychology with the practical, hard-hitting realities of organizational management. Together, we'll examine the fragile ecosystem of residential youth care, looking closely at how the deep, complex needs of traumatized children intersect directly with the everyday stress faced by the professionals who care for them.
Let's kick things off by grounding ourselves in a truly staggering statistic provided by Kids TLC, which is an organization operating a psychiatric residential treatment facility. 80 to 90%.
That 80 to 90%? That represents the proportion of youth entering these facilities who have a documented history of severe childhood trauma, abuse, or neglect, along with totally disrupted attachments. Right off the bat, this creates immediate stakes for our discussion. We are fundamentally dealing with kids carrying heavy, invisible wounds that require highly specialized, sensitive care to heal.
So, here's our roadmap for today. 1. The invisible wounds. 2. Trauma-informed care. 3. The caretaker crisis. 4. Job embeddedness theory. And finally, 5. Training for retention.
All right, jumping into Section 1, the invisible wounds, understanding the clinical reality. Because of their pasts, these youth often meet the exact criteria for complex PTSD or developmental trauma disorder. And this trauma, it manifests in incredibly intense ways. We're talking about massive emotional explosions where youth might yell, throw things, or terribly, even resort to self-harm. As they reach adolescence, this can escalate into highly reckless behavior. But honestly, perhaps the most challenging manifestation is a profound, disorganized mistrust. These kids often feel they can literally only trust themselves, exhibiting a deep, deep resistance to the very adults who have good intentions and are genuinely trying to help them. To actually effectively treat youth with this level of trauma, the Association of Children's Residential Centers, or ACRC, insists on a massive mindset change. They've redefined a common medical concept for mental health, calling it a universal precaution. You know how a doctor just assumes any patient might have a blood-borne illness and automatically wears gloves? Well, mental health professionals in these settings must presume that every single person in the treatment setting has likely been exposed to persistently overwhelming stress or abuse. Basically, trauma is assumed to be in the room.
Moving right along to Section 2, Trauma-Informed Care, a paradigm shift. So how do facilities respond to that universal precaution? Well, they're completely overhauling their environments. Organizations like the ACRC emphasize that physical spaces themselves absolutely must be collaborative and supportive. A true trauma-informed environment strips away the locks, the barriers, and that stark, cold, institutional feel that just screams coercive control. Because think about it. Simply being placed in a residential facility is a massive loss of control and can be traumatic all on its own. The physical environment has to convey warmth, safety, and a sense of belonging to prevent triggering any traumatic reenactments. There is a really stark contrast between the old way of doing things and the new trauma-informed approach. Back in the day, facilities relied heavily on behavioral control, things like point and level systems, seclusion, and physical restraint. But we now know without a doubt these are highly re-traumatizing, mostly because they recreate the exact experience of the child having to work external systems just to survive. The new paradigm relies on collaborative problem-solving, sensory modulation rooms to help youth learn self-soothing, and expressive therapies like art and music so they can process trauma without getting locked into coercive power struggles.
Which brings us to a foundational mantra used by facilities like Kids TLC, rooted in dyadic developmental psychotherapy: connection before correction. When a child is acting out, staff are trained to approach with an attitude of playfulness, acceptance, curiosity, and empathy to create emotional safety first. By prioritizing that relational connection, staff avoid letting strong emotions hijack the whole situation. It's the connection itself that helps the child regulate and learn to trust again, definitely not the punitive correction.
Okay, Section 3, the caretaker crisis, the systemic threat.
Now, residential facilities are facing a massive, massive retention issue. While a healthy annual employee turnover rate in the broader working world hovers around 10 to 12%, residential youth care is seeing turnover rates of 20 to 40%. That is more than double the healthy average, and it is entirely disrupting the therapeutic environment. So why exactly is this happening? Well, staff are constantly subjected to vicarious trauma. They are hearing horrific stories of abuse and managing daily, high-stress behavioral explosions. They face excessive workloads and just profound emotional exhaustion. And here's why this matters so much clinically.
A therapeutic community is built on a transitional, safe attachment. When a worker burns out and quits, it literally shatters the consistent, safe attachments that these traumatized kids desperately need in order to heal. Turnover isn't just a frustrating HR problem. It is a full-blown clinical emergency.
Which leads us perfectly into Section 4, Job Embeddedness Theory, the Organizational Solution.
To figure out how to stop this bleeding, we can look at a fascinating 2024 doctoral study out of Walden University by researcher Fatima Silverstooth. This research focused heavily on job embeddedness theory as a really practical framework to understand exactly why employees choose to stay in these incredibly demanding social service roles, despite the huge emotional toll.
Job embeddedness theory, which was originally introduced back in 2001, actually flips the script. Instead of asking, why do people leave, it asks, why do people stay? It argues that retention relies entirely on building three core pillars. First up is fit, how well the employee aligns with the organization's culture. Second is links, the meaningful, supportive social connections they have with their colleagues and supervisors. And third is sacrifice, the positive benefits, both financial and emotional, that the employee would lose if they walked out the door for good. The goal is to root the employee deeply into the very fabric of the organization.
Interestingly enough, we can mirror our earlier clinical concept right here. The ACRC points out that organizations and the staff themselves are subjected to overwhelming stress. Therefore, leaders have to apply a universal precaution to their own workforce. Leaders need to just presume their caregivers are experiencing vicarious stress. They shouldn't be waiting around for staff to raise their hands and ask for help. They have to proactively design a supportive environment that builds those embedded links and offers shared governance to neutralize the feelings of helplessness that cause burnout in the first place.
And that brings us to our final section, Section 5, Training for Retention, a Roadmap for Leaders.
The Walden University research identified 4 specific thematic strategies that actually work to keep people around. It starts with intensive staff training so workers fully grasp the harsh realities of their roles, combined with training built specifically to boost their confidence in handling trauma. But here's the thing. It can't just be about the floor staff. Leadership themselves must be trained to offer highly active, supportive supervision and to implement structured, consistent ways to recognize their employees' hard work.
Out of all these strategies, the research highlights one key recommendation that is a literal game changer: simulation. Leaders must recreate training situations that deeply resemble the real-world, high-stress challenges staff will actually face in the facilities. By highly simulating these crises right during the onboarding phase, staff develop the necessary fit and the genuine confidence to handle emotional explosions before they ever even step onto the floor. It completely eliminates that initial shock factor that drives so many new hires to just up and quit within their first few months.
To wrap up this explainer, I want to leave you with this thought. We've seen today that the youth in these facilities are carrying immense, deeply painful, invisible wounds. But they simply cannot heal in a revolving door of burnt-out caregivers. Supporting the organizational needs of our staff, embedding them, training them properly, and recognizing their heavy emotional labor, that's not just some nice administrative goal. It is the absolute foundational prerequisite to providing the life-changing clinical care our youth deserve. Because at the end of the day, when we care for the caregivers, we heal the children. Thanks for joining me on this deep dive into the ecosystem of residential care.